안녕하십니까. 서울 강남치과 배정인 원장입니다.
Greetings, I'm Dr. Pejongin of Seoul Gangnam Dental Clinic. Today I'd like to talk about aesthetic complications related to anterior implant. The contents of today are as shown. Let's look at definition of terms. What I'm going to talk about is largely based on a lot of journals, so therefore it would be of great help if you look up these journals and read the abstracts. It'll be of great help. Let's look at the terms. Success and survival complication. Albrechtsen and Zarb in 1986 presented success criteria of implant treatment. The implant should not be mobile, there needs to be no peri-implant radiolucency, and there needs to be less than 0.22 millimeter of vertical bone loss per year. In addition, there needs to be no consistent signs and symptoms. In 2007, in the International Congress of Oral Implantologists, there was a consensus conference. PISA reported a study. Success is optimum health, survival is satisfactory or compromised state of health, and failure as a state where it requires removal of implant. The criteria used were mobility and patient symptoms as well as images. The success of implanted treatment was primarily about maintenance of osseointegration as implant survival rate increased and as implant treatment became more widespread. Recently, in 2012, the criteria projected by Papaspyridokos, I think this is Greek person, but the criteria presented by him became more widely used. In other words, the natural-looking soft tissue state, prosthetic component, aesthetics, patient satisfaction became new criteria for implant treatment. If you look at a fairly recent study in 2002 about the classification of complication in relation to survival, biologic complication, hardware complication related to superior prosthesis or implant component, and aesthetic factors needed to be classified. Today, we're going to talk about the aesthetic complications. This is in relation to prosthesis, hard tissue, and soft tissue. This classification is by me. Today, I'm going to talk about the peri-implanted tissue-related complications. How can we evaluate the aesthetic factors? Aesthetics is quite subjective, but if there are areas where we can objectify it, we need to evaluate, research, and improve it. In 2021, Hiossen et al. Presented a study in COIR. The soft tissue evaluation study was presented. About 15 studies are reported. It was referred to in Hiosen's study, but in 2021 at EAO conference, many people have cited the Verhauser index as the pink aesthetic criteria. In addition, EAO consensus recommends using digital scan to do a profilometric analysis, merging together the changes and analyzing them. In my past lecture, it's the same way as what is shown on lower right. Pink Aesthetic Score, or PES, evaluates 7 different items. The total score is 14, and you can grade from 0 to 2. Rather than using this to calculate score, you need to understand what kind of evaluation criteria there are for pink aesthetic scores. A lot of studies included this item. If you look at this table, the first and second is mesial distal papilla. If there is no papilla, it's 0. If it is incomplete, it is 1. If it is complete, it is 2. Third is level of soft tissue margin. The fourth is the soft tissue contour, the gingival margin area, and the emergence profile area. Depending on how natural it is, a score is given. Fifth is alveolar process. You need to evaluate whether it resembles that of adjacent tissue. Sixth and seventh is color and texture of soft tissue. It is graded along with the adjacent structure. Let's get an overall view on these reviews and items. Based on these evaluation criteria, we can get hint to prevent aesthetic complications. This review is done by Ramanaskaite. I think this person is from Lithuania. It's difficult to pronounce. Anyway, I want to take a deeper look at her work published in Periodontology 2000 and 2022 along with other references. It can be divided into 4. Factors associated with interproximal peri-implant soft tissue fill, factors associated with mid-facial peri-implant mucosal height, and long-term stability of peri-implanted tissues, as well as aesthetic compromise following secondary surgery after implanted treatment. If additional procedure is involved due to peri-implantitis, what kind of impact the aesthetics will have. These 4 factors were reviewed. In terms of papilla height, in 2018, there was second Osteology Foundation consensus meeting. In terms of single implant, clear evidence was presented that papilla height was determined by the clinical attachment level of adjacent teeth. This means the papilla fill is determined by the condition of adjacent teeth or the clinical attachment. Therefore, before we go in and do anterior implanted treatment, we need to look at the perio condition of adjacent teeth and do periodontal treatment first. The Tarnow rule, contact point and papilla fill showed limited evidence. In general, studies say that the closer the contact point and bone is, papilla fill becomes more complete. Tarnow mentioned that the limit was 5 mm. In consensus meeting, the accurate limit could not be determined. Conflicting research results were presented as well. This is something we all know, but the evidence level in literature was low gingival phenotype. We call this biotype. Thick biotype is more favorable than thin biotype. The distance with the adjacent tooth needs to be over 1.5 mm. But in the study, the evidence level was not high. Implant design can be divided into bone-level implant and tissue-level implant, but no statistical difference was discerned when to provide prosthesis after doing implant placement. People normally say that it is better to provide immediate prosthesis, but the evidence level of it is low. In the case of placing 2 implants, if the distance between the platform is within 3 mm, the papilla fill can be incomplete. Therefore, it is better to reduce the number of implants placed and to use cantilever or Pontic. The evidence level of it is not high. In this image, you can see what was just mentioned. In the upper left, the distance with the adjacent teeth is 1.5 mm and the distance to adjacent platform is 3 mm. You can see implants have been placed nicely. On the upper right, implant is quite close, and on the right side, papilla is fully gone. This is from a study. Midfacial mucosal height. In pink aesthetic score image, it is number 3. When we talk about gingival recession, we are talking about changes in this area. The factors that affect the gingival recession is, first, the buccolingual position and angulation. The most prominent is the study published by Buser and Belzer in 2005 in JOMI. Here, danger zone and comfort zone is defined regarding recession. If you place the implant too buccally, recession can occur easily. The comfort zone is defined not just buccolingually but mesiodistally and apicocoronally as well. If you look at the image in the middle, the emergence point of adjacent teeth, in the line that connecting this, it needs to be over 1 millimeter palatally positioned. If you place the implant more buccally, recession could occur according to Buser's study. But if we're talking about range, in other studies, they talk about 1 to 2 millimeters. If it is placed too palatally, ridge wrap design could be formed. Mesiodistally comfort zone would be defined as 1 to 1.5 millimeter distance with the adjacent tooth structure. In terms of apicocoronally, 1 millimeter below the gingival margin is the CEJ, and implant should be placed 1 millimeter below that. That is referred to as comfort zone. If the implant is buccally inclined, it can also lead to recession. I was not able to find a consensus report that evaluated evidence level. Second is gingival phenotype. Many people think that a thick biotype would have less recession, but if you look at the evidence level, it's contradictory. In thin biotype, if you do immediate implant placement, recession can be observed more frequently. We need to take note of this. There's limited evidence on implant design and on when to do loading. It is said that the platform switching design is more favorable and immediate prosthesis delivery is favorable. In the case of TS and KS implant, the platform switching is applied. Upon implant surgery, it is said that doing soft tissue graft would help in preventing recession. However, it does not affect marginal bone level, and there's no long-term evidence. If you do soft tissue graft, naturally, short-term, the volume would increase and recession would be reduced. I think that's inevitable. Unless there's inflammation, this is bound to occur. I hope there will be more long-term data on this. In the case of gingival recession and immediate implant placement cases, doing gap filling inside the extraction socket does not show meaningful differences. But the recession can be prevented by using a slowly resorbing graft material like xenograft. This is a standard care almost. In terms of long-term stability, in the case of single implant, papilla fill is increased if you look at 5-year result. I'm not sure whether it goes up or whether it's due to gingivitis, but it goes up naturally. In single implant cases, mid-facial gingival recession, in 8-year data, it is maintained stably. In immediate placement and conventional placement, once stabilized, there's no meaningful difference between the two. If you look at specific numbers, recession numbers are about 0.2 to 0.5 millimeters, and there is no statistical difference. When secondary surgery is done, peri-implantitis prevalence, according to JCP in 2015, is about 20%, but clinically speaking, it feels much higher. Peri-implantitis, gingivitis, I'm not sure whether the term is accurate, but when you consider peri-implantitis as well as peri-implant gingivitis, the prevalence will go up significantly. If there is bone loss, we find a surgical method to solve the issue. Access flap surgery, if this is done, we need to factor soft tissue recession. Once the surgery is done, if you do soft tissue graft, it would help in preventing soft tissue recession. This is a different study. This is not Ramanoskites' study. I think it's good for us to review this as well. Chen published this study in JOMI in 2014. Aesthetic outcomes were compared between immediate implant placement and delayed implant placement, looking at changes in gingival margin. Type 1 is immediate implant placement. Type 2, early placement with soft tissue healing. Type 3, the period was not specifically specified. Type 3 is early placement with partial bone healing. Type 4 is late placement. In the case of type 1, the amount of recession varied significantly, and the prevalence was higher even compared with early placement. In the case of immediate implant placement in type 1 cases, if you look at post-op CT, or when you do probing or open the flap, there were higher frequency of lack of facial bone wall, and in those cases, recession occurred more frequently. In type 2 and type 3, facial bone were observed more frequently. The integrity of facial bone is an important factor in long-term aesthetic outcome.
결론적으로 페이셜 본의 인티그리티 완전성이 롱텀 에스테틱 아웃컴에 중요하다고 했는데요.
The study does not specifically say it, but if you look at the conclusion, if the facial bone is too thin or if there's resorption, it may not be favorable to do immediate implant placement. It would be more aesthetically favorable if bone graft as well as soft tissue graft would be done after soft tissue or bone healing.
그리고 술자가 가능하다면 연조직 이식까지 함께하는 것이 심미적으로 유리할 수 있다고 볼 수 있겠습니다.
Let's look at other factors. In the anterior area, if you have used a 5mm implant to get primary stability, this would be excessive, and this would lead to having intervened in the danger zone, so it could also cause gingival recession. If the abutment pressures the gingiva too much, also this can lead to changes in gingiva. I have not introduced it yet, but in a study, if you use a stuck abutment, gingival height 1 mm and gingival height 3 mm were compared. The gingival changes were more stabilized when gingival height 3 mm option was used. Now I'm going to talk about treatment methods. Actually, there's no standardized information apart from textbooks. So let's look at studies once again. It is similar to doing root coverage to the exposed natural tooth. You can do coronally advanced flap with connective tissue graft, or you can do envelope flap pouch tunnel techniques with connective tissue graft, or you can take submerged technique where prosthesis is taken off and you can just submerge it. Next, you can do coronally advanced flap with an option other than CT graft. You can use a pedunculated connective tissue graft, free gingival graft, GBR, and other multiple surgical approaches in different surgical steps. This was introduced in a study in 2018. Majoti said that it is recommended to do coronally advanced flap with CT graft. In this review study, prosthetic surgical prosthetic, this combined approach was taken note of. Let's look at the process. The first image on the left, you can see gingival height is different with adjacent structure. Once the prosthesis is removed, for 1 month before surgery, you make sure that it is not in contact with adjacent structure as well as gingiva. Provisional is provided in this way. Soft tissue growth and maturation is promoted for 1 month. This is to remove negative impact coming from the prosthesis, and after 1 month, as is done with natural tooth, you do connective tissue graft along with coronally advanced flap. On the exposed implant, the surface diameter burr is used and rubber clamp for polishing. Depending on surgeon, some people prefer tetracycline. Soft tissue healing and maturation was continued without crown. Specific timing was not specified here. Screw-type temporary prosthesis was used for gingival molding, and final prosthesis was provided after 8 months since surgery. Then, how long did the patient live without the teeth? Maybe 6-7 months. Final prosthesis. If you look over here, crown was provided for adjacent tooth as well. If you compare with the initial visit, significant aesthetic improvements have been achieved and stable results were achieved even after 1 year. There are many good details in this study, so I really strongly recommend you to read this. Let's look at other treatment methods. You can use pink porcelain to camouflage the gingival level. If you use pink composite to resin together on the pink porcelain, you can hide the margin better. I've never used it. Rather than placing 2 implants too close to each other, it is better to use cantilever design to promote the papilla fill. Adjusting prosthesis contour, adjusting contact to minimize black triangle, and to apply Tarnow method. By adjusting adjacent tooth, we can reduce the negative impact on aesthetics. In my view, doing such treatment is not an easy process. It's not easy to address aesthetic complications, therefore prevention is the key. I would like to summarize my lecture. I've looked at term and definition of success, survival, failure, and complication. I've also talked about pink aesthetic score to evaluate the aesthetics. Next, I've looked at potential causes of aesthetic complication, as well as factors related to papilla and mid-facial recession, the long-term result, and the results associated with secondary surgery. The factors that come into the play: the period condition of adjacent structure, contact point, and phenotype, implant positioning, implant design, the time of implant prosthesis delivery, and the impact of hard and soft tissue graft. I'm sure you have a basic idea of what kind of impact it would have. I've talked about different treatment methods. Surgical methods have been iterated. I mentioned that it is very similar to root coverage method in natural tooth, but there's not a lot of data on that. Prosthetically, you can do camouflage technique. This is the end of my lecture. I hope it was of help in understanding, preventing, and treating aesthetic complications. Thank you.